Thank you for joining us. Today's topic is MIPPA and in-office MRI and what you need to know to continue Medicare payments for MRI ancillary services after January 1st, 2012. Today's featured speakers are Dr. Douglas K. Smith and Ms. Jennifer Harkins. Dr. Smith is founder and president of Musculoskeletal Imaging Consultants and a board-certified radiologist with additional orthopedic surgery training at the Mayo Clinic. Dr. Smith has been a pioneer and an expert in orthopedic and spine MRI imaging since 1985. He is an innovator in orthopedic radiology workflow efficiency and was awarded special commendation by the United States Air Force for his contributions to the Wilfred Haw United States Air Force Medical Center Orthopedics and Radiology Department. He is an experienced medical director and supervising physician for orthopedic groups with in-office MRIs. He is also an official team physician for the United States ski and snowboarding teams. Jennifer Harkins is the Chief Compliance Officer of Musculoskeletal Imaging Consultants and is a graduate of the University of Texas at Austin and Wayland Baptist University. Ms. Harkins holds a Master of Arts degree in Management and is a certified HIPAA professional. She assists orthopedic groups with compliance and radiology services on a daily basis. Ms. Harkins will discuss the importance of policies and procedures to meeting the MIPPA CMS requirements. Both presenters are employed by Musculoskeletal Imaging Consultants, an orthopedic teleradiology company with experience in assisting orthopedic groups and imaging centers in achieving accreditation. Neither presenter is affiliated with any other entity discussed in this webinar.
Thank you so much. We appreciate the opportunity to be presenting. I know that you all probably have different reasons for joining us today. Some of you may not know much about MIPPA. Others may know about MIPPA but need more information on the certification process. Also, there may be some who are already certified but want to know what new processes will be put into place in 2012. We will do our best to help all three groups with the information needed. Today we're going to talk about MIPPA requirements and how they might apply to you. We will talk about the three accrediting organizations that CMS, or the Centers for Medicare and Medicaid Services, have selected and what the requirements are. We'll go over what the responsibilities are for the medical director or supervising physician and what liability this role takes on. We'll go over new requirements for accreditation in 2012 and also give the opportunity to ask questions. Our objectives for the webinar are for you to gain familiarity with MIPPA and what the implications are for your practice, for you to understand the general requirements for MIPPA and what it takes to get accredited, for you to understand the differences between the three CMS-approved AOs or accrediting organizations, and the benefits and drawbacks of each to your group. We want you to really grasp and understand the magnitude of the medical director or supervising physician responsibilities and liabilities. You will learn about the new 2012 requirements for accredited sites and also the financial and legal implications for not getting a credit certified by January and complying with MIPPA standards. So, what is MIPPA? MIPPA stands for the Medicare Improvements for Patients and Providers Act and is federal legislation passed back in 2008. MIPPA applies to all those who supply imaging services and submit Medicare claims for the technical component of ADI, which is Advanced Diagnostic Imaging. So all imaging centers and physician groups who do in-office imaging are required to comply. MIPPA was designed to improve the quality of imaging by requiring certification through validating scanners, ensuring that policy and procedures are in place and that staff have the appropriate qualifications. The medical director or supervising physician takes on the responsibility of safety and quality assurance oversight. You may be wondering who is affected by MIPPA. Well, all non-hospital providers of advanced diagnostic imaging services that bill under Part B of the Medicare Physician Fee Schedule are required to get certified. The diagnostic services include CAT scans, PET scans, MRI, and nuclear medicine. It doesn't apply to X-ray or ultrasound procedures. You may be asking yourself why you should be concerned about MIPPA. Well, all non-hospital imaging providers must be accredited by one of the three Medicare-approved accrediting organizations by January 1st, 2012 to continue to receive payment for the technical component of services. The entire process must be completed before January. Medicare will not reimburse those who are mid-process or even almost completed. There is no grace period. Now you might be thinking, holy mackerel, what do we do? Let's ask Dr. Smith.
Thank you, Jennifer. The take-home message of this webinar is initiate the process today. First, choose the best accrediting organization for your practice. In this webinar, we'll give you some guidelines on how to choose which AO is best for your practice. Second, identify the appropriate members of your application team. That includes a supervising physician, technical supervisor, MRI physicist, and perhaps a consultant in MIPPA. Third, initiate the online process today. Fourth, identify a supervising physician with the required training and experience and the willingness and availability to assume the considerable responsibility, time commitment, and liability of the MIPPA maintenance phase. And lastly, if you do not already have established policies and procedures in place, consider engaging a consultant or a teleradiology company with experience with the MIPPA process and maintenance. We talked to a number of orthopedic groups throughout the country, and we've discovered there are a few common MIPPA misconceptions. The first is MIPPA accreditation is just as simple as sending a few sample MRI images from our scanner for review. We also hear all we need to do is submit the name of one of our physicians in the Medicare form that asks for supervising physician to meet the criteria. We've heard that we do a good job already, so there's no need for all the written processes and procedures they talk about. Nobody checks anyway. Or, we have plenty of time. Medicare has a grace period for in-process applications. Or, we can fudge the application for now. We'll complete the process later. Or lastly, peer review is not really necessary. Our doctors read their own MRIs. We're going to show you in this webinar why most of these misconceptions can be costly and threaten your application or result in fines or risk of imprisonment. I'm going to talk a little bit about the three approved accrediting organizations. Medicare, or CMS, Center for Medicare and Medicaid Services, has authorized three accrediting organizations to approve sites for MIPPA. The first is the American College of Radiology, or ACR. The second is the Intersocietal Accreditation Commission, or IAC, and the third is the Joint Commission, or TJC. Each of them has specific characteristics that may make them a good or bad choice for your orthopedic practice. The American College of Radiology, or ACR, is the representative body for radiology. It maintains the gold standard for best practice standards for imaging policies and has been an accrediting facility since 1963. The ACR process for accreditation includes an evaluation of the technical performance of the MRI scanner by submission of phantom images. We'll talk about this in a minute. The application also requires submission of clinical images that are peer-reviewed to evaluate for technique and image appearance. The application requires technical and quality assurance policies and procedures, but the ACR does provide an extensive library of best practice policies and procedures from which you can fashion your site's protocols. The ACR does not mandate report format or content and does not require clinical correlation. The ACR suggests allowing 4 to 6 months for completion, and the cost is $2,400. Recently, the ACR has guaranteed a response within 90 days of receipt of your sample images. The IAC, or Intersocietal Accreditation Commission, is the most commonly utilized AO for in-office imaging. It uses a clinical context for device certification, and it mandates standards for report content and format. There are also mandates for technical and interpretive quality assessment requirements, but the IAC provides limited guidance in this area. The IAC is a great choice if paired with a seasoned medical director and established policies and procedures. The IAC is divided into 6 divisions according to the imaging modality that's being accredited. In most cases, an orthopedic group would be applying to the ICA MRL, which evaluates magnetic resonance imaging. The Joint Commission, or TJC, is best known for hospital and health system accreditation. It's a best choice for multi-site and multimodality facilities such as hospitals. It involves an initial on-site visit with subsequent unannounced inspection. It focuses on the facility-specific characteristics and quality control programs such as in hospitals. It also requires 4 to 6 months to complete and costs $8,500 to $12,500 depending on the number of patient visits to the facility. This is not the best choice for most orthopedic practices, and I will not discuss this further in the webinar. Medicare, or CMS, which is the Centers for Medicare and Medicaid Services, has established basic qualification standards for each of its 3 accrediting organizations. These general categories must be fulfilled for each applicant, but they leave it to each accrediting organization to determine the details of the requirements. In general, these are in broad categories of personnel qualifications and processes and procedures. Under the personnel qualifications category, there's a category for physicians and for non-physicians. The physicians have specific requirements for both the supervising physician and the staff physician, and the non-physician requirements include technologists and non-technology staff. There's a broad area of processes and procedures, including categories for patient and staff safety procedures and quality assurance procedures. The responsibility of the medical directors and supervising physicians are specifically detailed. There are also equipment performance specifications that must be met, including initial testing and quality assurance procedures. We'll talk a little bit about MRI technical accreditation. The ACR certification for MRI involves application for 1 to 6 modules depending on the scope of practice. Most orthopedic groups would apply for the orthopedic or musculoskeletal module. Groups that perform spine imaging would also apply for the spine module. Very few of the orthopedic practices would apply for the head and neck or neuro module, body module, MRA, or cardiac modules. The ACR certification includes submission of images in the clinical and phantom categories. The clinical images include 4 to 6 patient MRI examinations, depending on the number of modules for which the applicant is applying. These include the knee, shoulder, wrist, elbow, or forefoot, and the submission must include at least 1 specialty exam from above. All of the images must be from patients and not from volunteers. The ACR requires submission of MRI imaging from the Phantom. The Phantom allows the testing of the technical performance of the MRI scanner. The testing criteria are independent of the field strength of the magnet. However, the ACR may customize the Phantom testing by magnet type. Both the clinical and Phantom images are submitted by CD. The ACR requires the scanning of Phantom images. In my opinion, MRI imaging is like great music. It all depends on being in tune. You can have a great song to sing, but if the guitar is out of tune, it just doesn't sound very good. On the right is a cylindrical shaped Phantom that's placed in the scanner, and Phantom images are obtained of this Phantom. Scanning a test Phantom evaluates the technical performance of the MRI scanner. A properly tuned MRI is required to produce optimal clinical images, and images from a properly tuned MRI are sharp and without artifact. To the lower right, you see scans of Phantoms with artifacts. On the left, there's a double vision type appearance with ghosting of the Phantom above and below the true Phantom. On the right, you see the unsharpness or motion type artifact created by improper tuning of the magnet. When the MR scanner is out of tune, the phantom images show unsharpness or artifact and may not be visible on the clinical images. Correcting the artifact or tuning the magnet improves your image quality and the appeal of your magnet in the medical community. The ICA MRL uses a case submission protocol. The applicant submits 5 case studies demonstrating pathology including the knee, shoulder, and 3 other joints. The submission includes clinical information about the patient in the case, scan parameter worksheet which includes the MRI settings, and the MR images including the scout images. No phantom images are required for the ICA MRL. The cost and time required are approximately the same, although the ICA MRL does not guarantee an answer in 90 days as does the ACR. In my opinion, not evaluating the phantom images loses the opportunity to identify and correct problems that may improve the quality of your MRI images. One of the categories is personnel qualifications. We'll talk now about supervising physician requirements. This is a busy slide, but I'll try to summarize it for you. On the left are the ACR standards for the supervising physician, and in the right column are the ICA MRL standards for the medical director. These are the same roles, just different names for each of the AOs. In the top row, you'll see the requirements for an applicant with radiology training. On the left, an ABR or board-certified radiologist needs to have interpreted 300 MRI examinations to qualify in addition to their board certification. A radiology residency-trained applicant without board certification has an increased requirement of 500 MRI interpretations in 36 months. On the right, you'll see an ICA MRL applicant with formal radiology residency training has a requirement for interpretation of 300 MRIs within 36 months. At the bottom half of the slide are the requirements for a non-radiology trained applicant. For the ACR, a non-radiology specialist must complete 200 hours of Category 1 CME in MRI. Listed below, this training must include training in MRI physics, MRI safety, MRI instrumentation, recognition of MRI artifacts, and clinical application in the specific subspecialty, in this case orthopedics. In addition, the applicant must have interpreted 500 MRI examinations within 36 months. On the right, you will see the bottom 2 categories for the ICA MRL applicant are divided into an established practice category or grandfather clause and an informal MRI training category. Under established practice, these include a board-certified physician with at least 5 years of experience. There's a requirement of 150 hours of CME in MRI with the same training requirements as for the ACR. In addition, there's a requirement for interpretation of 1,000 MRI examinations. In the informal MRI training category, there's a requirement for 150 hours of CME in MRI with the same component training. This is the most likely category for a non-radiology trained or orthopedic medical director. There's also a requirement for 6 months observing interpretation of MRI examinations with at least 300 MRI examinations being interpreted during that time. Although this is the lowest training threshold and easiest way to meet the criteria for medical director, it also provides the least preparation for the medical director responsibilities that we'll discuss later. The ACR summarizes the supervising physician responsibilities as developing, implementing, and enforcing policies and procedures, including magnetic resonance safety, contrast use and sedation, MRI for pediatric patients, quality control and improvement, safety, infection control, and patient concerns, and identifying patient or potentially pregnant patients. This is only a partial list. There are a few challenges for a non-radiologist medical director when applying for the ICA MRL. The ICA MRL has extensive mandates but very few templates for execution. Unless the applicant has extensive experience or training in the management of an MRI scanner and these policies and procedures, this can be a very daunting task. The ICA MRL has detailed report formatting requirements, including style and content. The required technical quality assurance mandates require technical training in magnetic resonance imaging for successful application, and these can be very difficult to acquire in general CME training. There are also detailed patient safety requirements, including handling patients with implantable devices and patients with impaired renal function needing contrast and contrast reaction procedures. Radiologists have specific training in these areas. This may be very difficult experience and training for a busy practicing orthopedist to acquire. We'll talk some about patient and staff safety procedures. In general, safety guidelines, practices, and policies shall be written, enforced, reviewed, and documented at least annually by the MR supervising physician. The ICA MRL has policies and procedures related to 9 personnel and patient safety categories and 6 MRI technical safety categories. The ICA MRL provides no templates and very limited guidance in the creation of these processes and procedures. The ACR, however, provides detailed best practice guidelines with recommendations in each category. I serve as a radiology expert witness, and in many cases I'm asked to evaluate whether the ACR guidelines are met. The ACR guidelines are considered as the gold standard for medical legal standard of care in most cases. Compliance with these guidelines provides a safe harbor for most imaging centers. The ICA MRL has an extensive list of requirements in the patient and staff safety areas. These are just some of the requirements, and I'll highlight some of them. There must be a mechanism to identify and manage high complication risk patients, including those with pacemakers, neural stimulation catheters, and aneurysm clips. There must be processes and procedures for controlling spread of infectious disease, and there must be direct physician supervision of all contrast and sedation. This means that a responsible physician must be present and supervise all administration of contrast and sedation. This can be very difficult to apply in a busy orthopedic practice. There must be written safety policies regarding magnet field safety, and there must be processes and procedures for handling emergencies, including an MRI quench. There must be policies for MRI contraindications for devices such as pacemakers and neural stimulators, and for contraindications for ferromagnetic implants. There must be policies and procedures that address possible contraindication, including nephrogenic systemic sclerosis, and specific policies must be in place regarding adequate education, training, and screening of all MRI staff. Needless to say, this can be a daunting task for many orthopedic medical directors. I'm going to turn this back to Jennifer to discuss quality assurance procedures.
It is critical for your site to have a quality assurance and quality control program. The MR equipment specifications and performances should meet all state and federal requirements such as magnetic field strength absorption rate and noise levels. The medical director or supervising physician is responsible for ensuring that quality control performance testing is conducted at least annually by the MR technologist and service engineer. Also, the medical director or supervising physician is responsible for an annual review of safety policies and procedures and making sure that peer reviews are conducted regularly. So what exactly is peer review? It's two physicians interpreting the same study, so essentially a double reading. The studies are randomly selected and should reflect the case mix of the practice. The medical director or supervising physician should have policies and procedures in place for handling significant discrepancies in peer reviews. The ACR uses a program that they designed called RadPeer that is a subscription-based service that gives summaries for each physician and summaries for each practice or facility. The Intersocietal Accreditation Commission requires their peer review program have predefined indicators of quality and predefined thresholds that indicate that some type of corrective action plan is needed. The medical director or supervising physician should maintain reports and is responsible for corrective action. The program should also include a correlation of interpretation of studies with patient outcomes. And the IAC requires the peer review program to show reproducibility of interpretation with the previous interpretation. The IAC doesn't offer much more in peer review methodology or guidance. So what do you need to think about if you're already certified? There are some new standards for 2012. It must be verified that all personnel have the appropriate training and credentials that can be verified at the primary source. For example, verification of the technologist schooling, licensing, and training must be directly received from the school or licensing program. Sites must make sure that patients have access to information policies, and there must be a record retention and retrieval policy in place. Every site must have a posted notice letting patients know how to file a complaint with the site's accrediting organization. Accrediting organizations are required by CMS to conduct unannounced audits, so it's critical to have policies and procedures in place for staff and patients. There is such a thing as a provisional accreditation status. If there's a site that's already accredited that plans to purchase another scanner or open a new location, the site will be given 120 days from purchase date or location opening date to update accreditation. Payment will continue as long as accreditation is updated in the interim. Sites are also required to have a protocol for patient complaints. They must be written and signed by the patient, and the site accrediting organization should investigate all complaints and report to CMS on a monthly basis. A complaint must be reported within 2 business days if the site condition poses immediate jeopardy and/or if the health of the patient or general public is jeopardized.
Thank you, Jennifer. We're frequently asked which AO is best for us. In this webinar, we'll try to give you the information necessary to make your own choice. The first is a joint commission. I think this is easy. This is not the best choice for most orthopedic groups. It's expensive and requires an on-site visit and does not provide the processes and procedure templates required to set up your own protocols. The ACR is the most prestigious and the oldest AO. It has gold standards for imaging processes and procedures, and it has an extensive resource library for supervising physician reference during the maintenance phase. The IAC is the most commonly used by independent doctor's office with access to the clinical information for case presentation or submission. It's a good choice if the experienced supervising radiologist or physician engaged with your MIPPA application and is willing and able to commit to the extensive MIPPA maintenance plan. I wanted to issue a couple serious warnings. The medical director is personally attests to the site compliance and is responsible for reporting changes to the accrediting organization. CMS and the AO will perform unannounced site visits to confirm compliance. Compliance with all standards will be expected. Misrepresentation of information is now a federal crime under the False Claims Act and False Statement Act and subject to fine and/or imprisonment. The AO must submit an annual report and share accreditation information with CMS, including the results of its site visits. Now to a lighter note. Marketing your accreditation once you've become accredited. The ICA MRL hosts a searchable list of ICA MRL accredited facilities online. These are readily available to your prospective patients or referring physicians. The ACR provides customized marketing materials for all its accredited ADAs. This includes accredited facility logos that you can include in your marketing materials and proudly post in your imaging centers. So how can a radiologist consultant give you a leg up in your application? Well, an experienced radiologist can help assist you in selecting clinical MRI images to present to the accrediting organization. The radiologist can confirm that they're appropriate images, free of artifact, and that the MR technique is optimal. A radiologist can also preview your phantom images before submission to the ACR. Phantom images that include artifact may delay or discredit your application. And since time is of the essence, there's no real time for delays at this point. How can a teleradiology company limit the pain of the MIPPA maintenance phase? Well, an experienced radiology supervising physician can provide the policies and procedures required for your scanner accreditation and for the MIPPA maintenance phase. An experienced teleradiology group can not only provide expert readings, but real-time, ongoing quality assurance, assessment, and corrections, and can provide the required peer review required by the MIPPA accreditation maintenance phase. So the take-home message is apply for MIPPA accreditation today. Start clearing away the hurdles that will prevent you from meeting the accreditation deadline of January 1st, 2012. And take home, don't let your Medicare dollars just walk out the door at the first of the year. I'm going to turn it back over to Jennifer for questions.
If you have any questions, our contact information is at the end of the presentation.
So musculoskeletal imaging consultants is considered by many to be the premier subspecialty orthopedic teleradiology company. We were founded by an orthopedic radiologist with training in orthopedics at the Mayo Clinic, and we specialize in orthopedic and spine imaging. We offer a dedicated seasoned MSK radiologist for your practice. You will get to know this radiologist well. We leverage technology to maximize service. Our founder is quite familiar with the pressures of a busy orthopedic practice and the needs of the surgeon within the OR. Our business model was featured on Inside Business with Fred Thompson documentary. This appeared on CNN, CNBC, and Fox Business News. We've recently been featured in Self magazine. Dr. Smith is our founder and is the official team radiologist for the U.S. ski and snowboarding team. That completes the webinar. Now for the pitch. MSKIC is a unique, dedicated orthopedic and spine teleradiology company that emphasizes radiologist accessibility and service. We offer dedicated, seasoned MSK radiologists to your group for your immediate needs. We leverage technology and are cloud-based, handheld-friendly, web-accessible, and HIPAA high-tech compliant. We are experienced with MIPPA and supervising physician and medical director roles, and most importantly, we want to meet all your imaging needs. Please contact us today and let us show you how we can help your orthopedic practice.